Dear colleagues, ladies and gentlemen, welcome to the NVM Cardiology meeting reflections for Radcliffe Cardiology. My name is Nicolas Van Mieghem, and I will be reviewing the late-breaking clinical trials at AHA 2025 in New Orleans, at least the trials that I thought were of interest from an interventional cardiology point of view. So let's start off with the trial that maybe was a little bit unexpected, and that is Closure AF. This was a randomized controlled study looking at the effects of LAA closure, transcatheter LAA closure with commercially available devices in patients at high risk of stroke and also high risk of bleeding. This randomized controlled trial was randomizing patients to LAA closure or standard of care treatment, and in the majority of cases, standard of care was DOAC or NOAC, so non-vitamin K oral anticoagulant drug therapy. 912 patients from 42 German sites. The mean age was 79, 40% were women. The mean CHA2DS2-VASc score was 5.2 and the mean Hesblad was 3. I think this is already important because a mean Hesblad of 3 means that those were not the patients that were at the highest risks for bleeding. Median follow-up was 3 years, and patients received also dual antiplatelet therapy for some time, 6 weeks to 3 months after LAA closure, followed by single antiplatelet drug therapy. In the standard of care arm, it was oral anticoagulant drug therapy, as mentioned. The primary endpoint was a survival time free of the composite of stroke, systemic embolism, major bleeding, and cardiovascular or unexplained death. And then the results. The primary endpoint was 16.8 per 100 patient years versus 13.2 per 100 patient years in favor of standard of care. That came as a surprise because we already have some trials that compared LAA closure with vitamin K and oral anticoagulation or oral anticoagulation in general. And then it seemed to be that the LAA closure was non-inferior for major adverse events. And all of a sudden here we have more issues. And this was driven obviously by more bleeding. The sweet spot of this trial is that, and what I was missing was, okay, but how many of those patients were really unable to take oral anticoagulant drug therapy because of this very high risk for major bleeding? And that was missing and I feel that is the sweet spot of LAA closure. And hopefully future trials can address this in a randomized fashion, but that means that we really have to pinpoint the phenotype of patients that might benefit most for this therapy. And this is important also for many geographies where there are some economic restrictions, right? You cannot keep coming up with new devices and then claim that they're to be used for all. So I think we need a little bit more precision medicine. And as you will notice, precision medicine is exactly the theme of this meeting, because look at the top randomized control trial. That is the next randomized study that was looking at the benefits of a liberal transfusion strategy, meaning starting red blood cell transfusions triggered by hemoglobin less than 10 grams per deciliter, versus a more conservative approach where the trigger to provide or to give red blood cell transfusions was at a hemoglobin level below 7 grams per deciliter. This study was conducted in the Veterans Affairs Health System. More than 1,400 patients who were undergoing open vascular or general surgery and were at high risk for cardiovascular events were included, and the composite endpoint was all-cause mortality, myocardial infarction, coronary vascularization, acute renal failure, ischemic stroke, up to 90 days after randomization. Turns out that there was no difference between the two treatment strategies, so a more liberal versus a more conservative transfusion strategy. But if you look then more carefully to the data, then we did find more heart failure and arrhythmia events in the restrictive group. So I do believe that also here there are patients that might benefit from a more aggressive red blood cell transfusion strategy. as compared to to other patients where a more restrictive strategy might be the way to go. And this all, I think, revolves around patient phenotypes and risk profile. And to some extent, I mean, we did not get too much granularity of the kind of patients that were enrolled in this study. And I can imagine that this is where precision medicine comes into play. The higher risk profile of the patients, the higher the likelihood to be a little bit more aggressive with transfusion strategies. But should we have a liberal use of our resources to all the patients? The answer is no, based on this trial. I think a very interesting trial was the Celebrate randomized control trial presented and led by Arnoud van Hoff from Maastricht. This was looking into the value of an injectable GP2B3A pharmacotherapy named Zalunfiban or Dizacpro. And the interesting part is that this is less than 1 cc that needs to be injected subcutaneously in STEMI patients. This was a trial that enrolled more than 2,400 patients in the US and in Europe, and patients were randomized to either Zalunfiban or placebo in the ambulance. So the therapy was provided to the patients in the ambulance before they entered a PCI center. There was already a press release that stated that Zalunfiban improved outcome, and the efficacy endpoint at 30 days was death, stroke, recurrent MI, acute stent thrombosis, new onset heart failure or heart failure hospitalizations, and also an increase in troponin levels. There was also a safety endpoint that was bleeding. I looked forward to this trial, and I think this trial also lived up to the expectations. The time from symptom onset to drug delivery was 90 minutes, and the time from symptom onset to PCI was 140 minutes. So there was this time interval of 50 minutes between the injection of the drugs and the PCI. And I think this is very relevant because time is muscle. So we want to be doing something in that time window that the patient is being transferred to a PCI center for opening the vessel. And treatment with Zalunfiban indeed reduced the risk of the primary endpoint by more than 20%. And I think this is quite relevant because it was driven by a reduction in the risk of acute stent thrombosis within 24 hours. And also the increase in cardiac troponin levels was lower in the Zalunfiban group. Also, 50% of the patients in the treatment arm had a TIMI grade 2 or 3 in the infarct-related artery at the time of angiography versus 45% in the placebo arm. So the patency rate upfront and also the normalization of the EKG upfront was higher in patients receiving the study drug. Was there a penalty? Not in terms of severe or life-threatening bleedings, although there were more mild or moderate bleedings in the glycoprotein inhibitor treatment arm. But that is not unexpected because you are giving antithrombotic therapy. So you would expect some kind of increase in bleedings. As long as these bleedings are not severe or life-threatening, I think we can live with that. And this opens up opportunities for pharmacotherapy in patients having a STEMI. But I also feel that this therapy might become relevant in a non-STEMI situation where patients typically, or high-risk patients, are typically treated within 24 hours. But what can we do then running up to the PCI intervention? Well, maybe this new family of GP2B3A inhibitors might become of interest. So I hope that we will see more trials with this drug that may refine the treatment of patients with ACS. Talking about patients with ACS, also the NEO mindset was revisited at AHA. Mind you, the trial was presented at TCT, and it was a little bit of a surprise because the single antiplatelet therapy in patients with ACS and single antiplatelet therapy with potent P2-112, Y12 inhibitors was inferior to dual antiplatelet therapy for 1 year in terms of major adverse cardiovascular events. And that was a little bit unexpected, in my opinion. So now we had a predefined sub-study of this trial looking at STEMI patients and non-STEMI patients. Mind you, more than 2,000 patients in NEO-Mindset were STEMI patients, more than 1,200 patients were non-STEMI patients. Well, it turns out that for both for both cohorts, a single antiplatelet therapy resulted in a 50% reduction in bleeding, and that is as expected in favor of single antiplatelet therapy. But in the STEMI cohort, there were more major adverse events, 8% versus 5%. And this was not happening in the non-STEMI group, approximately 5 to 6% event rate in both treatment strategies. And I think this is very relevant because it sheds some light on this study from Brazil. And we have to also mind ourselves that this study was being conducted in Brazil. The question is how this will translate in Western societies in the United States, in Europe, or in Asia, for instance. So I do feel that this is not the end of the story, and I really look forward to the trial outcome data from Legacy. That is a randomized controlled study that is led by our friends in Amsterdam, where they are looking at single antiplatelet therapy versus dual antiplatelet therapy, specifically in patients with non-STEMI. And then there is also the Compare STEMI 1, that is a randomized controlled study only in patients with STEMI, randomizing patients to 1 month versus 1 year of single antiplatelet therapy or dual antiplatelet therapy. Why would why would dual antiplatelet therapy be more beneficial in STEMI patients than in non-STEMI patients? Well, you can come with some hypotheses. Maybe there is a higher thrombus burden or more microvascular dysfunction in the context of STEMI patients that might require more aggressive antithrombotic therapies. Potentially, but I do feel that we need more data than just NEO-Mindset. This is just the beginning of potentially also precision medicine here, right? So some patients might benefit more from DAPT and others don't need aspirin on top of potent antiplatelet therapy. So I think more trials in the coming years to look out for. And then the last trial that I wanted to mention is the DAPA-AF randomized controlled study. This interesting trial, mechanistic trial, was looking at the effects of dapagliflozin, so SGLT2 inhibitors, in the prevention of AF recurrence in patients undergoing catheter ablations for persistent atrial fibrillation. 200 patients with a mean age of 58, 1 in 5 are women, approximately 30% had persistent atrial fibrillation that lasted for more than a year. Well, at 3 months post-ablation, SGLT2 inhibitors did not have any effect on the recurrence rate of atrial fibrillation. And also, there was no difference in the recurrence rate of atrial arrhythmias in general between the two treatment strategies. So I don't feel that we have any argument to give SGLT2 inhibitors to all patients with any kind of cardiovascular disease. Mind you, there is also this DAPA-MI randomized controlled trial that also showed that there was no real benefit in major adverse events with SGLT2 inhibitors immediately or early following STEMI treatment. So with that, we're coming to the end of this wrap-up of the AHA 2025. I hope you enjoyed it. Hope to see you also next year for more reflections on the cardiology meetings for Radcliffe Cardiology.